Good morning or good afternoon, wherever you are joining us from today. And welcome to the Child Neurology Foundation 2016 webinar series, Child Neurology Community Conversations from the voices of the provider, the parent, and the advocate. My name is Stacia Grace. I'm the Director of Operations here at Child Neurology Foundation. On behalf of our Board of Directors and Corporate Advisory Partners, we are excited to bring you this latest episode of our webinar series that will focus on transitioning youth living with neurologic conditions to adulthood. We are incredibly lucky to have a panel of experts with us today to help us better understand the divergent perspectives as well as the shared understandings regarding the transitions process. Before getting started, I wanted to briefly highlight who Child Neurology Foundation is, for those of you just learning about us, as well as our work to support youth, families, clinicians, and the child neurology community in transitions of care. Child Neurology Foundation is a national nonprofit committed to serving as a collaborative center of education and support for children and caregivers living with neurologic conditions. In particular to the issue of transitions, CNF is proud to have led the child neurology community's most paramount effort in transitions since 2014, with the authoring of the consensus statement, The Neurologist's Role in Supporting Young Adults Transition to the Adult Healthcare System, which was published in the Neurology Journal in July 2016. You'll hear more about this statement today during today's webinar. This consensus statement has been widely endorsed by other leading neurology membership bodies and presented to several disease-specific advocacy groups across the nation. As you will learn, it provides step-by-step guidance for how neurology teams can partner with youth and families to plan for transitions starting at age 12. Additionally, CNF developed an interdisciplinary expert body in 2015, the Transition Project Advisory Committee, to help work towards implementing the consensus statement's recommendations. Their work has focused on the areas of youth and family education, clinical tools, and quality efforts. To learn more about their work, please visit our website at childneurologyfoundation.org. and click on our Transitions page under the Parents, Patients, and Caregivers menu. CNF would like to thank our Corporate Advisory Board members as today's sponsors for the call. In particular, a special thank you to ASI, who has served as co-sponsor to the past 2 years of work CNF has done on transitions. So with that brief introduction, let's get started. A few things to note. Each of our presenters will speak approximately 15 minutes. Feel free to be sending in via the chat function your questions, and we will be posing those to our panel at the end of the call. We'd like to hear your voice as well in this conversation, so asking questions is a great way to do so. Our first panelist today is Dr. Larry Brown. He is Associate Professor of Neurology and Pediatrics at the Children's Hospital of Philadelphia and the Perelman School of Medicine of the University of Pennsylvania. Dr. Brown is the past president of the Child Neurology Foundation. He currently serves as chairman of its Medical Transition Initiative, which is defining the goals of successful transition for youth with neurologic disorders. Locally, he is co-investigator of an epilepsy education and transition project funded by the Health Resources Services Administration, in collaboration with the American Academy of Pediatrics. Dr. Brown is a senior clinician in CHOP's Pediatric Regional Epilepsy Program, where he continues to be principal investigator on numerous clinical drug trials in pediatric epilepsy. He is also a director of the Pediatric Neuropsychiatry Program, a multidisciplinary clinic for children with Tourette syndrome, high-functioning autism, complex ADHD, and genetic disorders where complex learning and behavioral issues have a neurobiological basis. He is a principal investigator of a genetic study funded by the National Institutes of Health as part of an international consortium to develop a worldwide databank of individuals with Tourette syndrome. In addition, he is also a senior clinician in the Sleep Disorders Center with a major interest in how sleep and its disorders interact in children with neurological and developmental disorders. Welcome, Dr. Brown, and thank you for being here today.
Thank you, Stacia, and welcome to everybody. I hope the current hurricane is not affecting anybody online. Take care of yourself first. What I'd like to do today is talk about how we got to where we are in our transition planning and what we would like to do as we move ahead, with a special emphasis on the neurologist's role and how parents and advocates can help. First of all, I think we need to understand what is transition. Just as we prepare for any change, whether it's vacation or movement from high school to college, we need to take time to get ready. And we do need to take time to get ready for the transition to adult medical care. And this can take many years of preparation. And as you've already heard, we are recommending, with good reason, to start at the very beginning of adolescence because it will take that long to complete that transition. It's only the last step, which is that movement from one caregiver to another, what we call transfer, that many people think of. But I want everybody from the outset to realize that transition is the process and not the moment in time. Now, I think everybody will agree that adulthood is inevitable, that we have specialists who are there for children and others for adults, and we also recognize that even those with neurological and intellectual disabilities have medical issues that should be best managed by adult physicians, but we've been stymied as a field, and many families are stymied about whether or not it's time to or how to move on. And despite the awareness of all of the above, child neurologists in particular have been either unfamiliar with, unwilling, or unable to help and guide their patients to the next step. There are a lot of barriers to that, and I don't want to spend too much time on it, but I think if you're a parent or a caregiver or even a professional, you'll recognize that we have grown up with the families, with the child. We understand all the challenges that they've had, and our history may go back, as with many of my patients, to the first days of life. So we're talking 20 or more years together. Also, you need to understand that there is a difference between the way pediatricians view their responsibility and how most adult providers do, where pediatricians and pediatric specialists tend to think of themselves as much more comprehensive, dealing with the child in the context of the family and their environment, as opposed to the adult providers who are dealing with a specific medical issue and leave the rest to others. Also, we've been very successful in recent years, and while a generation ago, if you had muscular dystrophy, you might be expected to live to 20. Now, the life expectancy is well into the 6th decade. And so we have new diseases and old diseases that never had the life expectancy, and our colleagues are not comfortable and not experienced with many of these issues. One of the biggest problems, I believe, is that there are very few adult practitioners who look forward to having a behaviorally disordered, intellectually disabled, and very complex child in their waiting room disrupting things. And especially they often have medical assistance and other poor insurance forms. But one of the most important issues that is a barrier is what we know, that at this age of early adulthood, the brain is not fully developed, and people tend to think they're going to live forever, tend to think they can do it on their own, and there's a big risk of dropping out. So when we make the movement from a pediatric to an adult care, we run the risk of not having the continuity of medication, not having the anticipatory guidance, and losing the controls that we've had. If that's not enough, there's very little reimbursement at the moment for transition care. None of these, by the way, should be rather barriers that preclude what we're going to talk about. From the perspective of the adult provider, who should be at the other end of the bridge to catch the patient, they have told us that they have a number of complaints, and this is just a few. The first is that they come and have not yet identified a primary care provider, that neurologists are specialists, they're not the PCP, and they need somebody to provide that. Often they arrive at their office without a detailed history, and people either don't remember or it's not clear. And the worst thing that I hear from my colleagues is that they're asked for prescriptions or for forms to go to the Motor Vehicle Bureau even before they get to see the patient and before they have a therapeutic relation. From the parent's perspective, they need to understand something, and that is that the adult culture, as I've mentioned, is different than the pediatric culture, that these visits are patient-oriented. Often the parents are not invited into the room. The focus is strictly on the neurologic issues for the most part, and they're referred to the psychiatrist or to the kidney doctor or the PCP for other issues. And we are very fortunate, in addition to everything that we get from parents and schools, we have social workers and even transition coordinators in many places. This is a picture that I got from one of my colleagues from the Mayo Clinic, showing the difference between the pediatric office and the adult office. And I ask you which one anybody would rather be going to. The left, by the way, is not Las Vegas. It really is the pediatric office. So we have based our work on a project that preceded us in 2011 and developed the core elements for general medical transition. And this comes from a paper sponsored by the Academy of Pediatrics, Family Practice, and the College of Physicians. And basically it outlined the work that we did, where you have a policy, you develop it, you get ready, and you transfer care. And at some point, care is transferred and transition is complete. This was done for general medical care, and there was a charge to all subspecialists to develop individual and unique ways that it might play out in their areas. And I'm proud to say that neurology is the first field that has taken on the charge and has done as much as we've done. Just so you know, it was not us in 2016, but back earlier that it was recommended that we begin this process at 12, and it's based on good scientific principles that by age 12 most children are able to participate in research activities with assent, that they understand what's happening to them and should be able to participate in their own medical self-management. And then it's a gradual process, as we'll go into in the next few minutes. So what did we do as a field of child neurology? We brought together neurologists, both pediatric and adult. We brought together child neurology nurses, primary care providers. We had an occupational therapist who's also the dean of an allied professional school. We brought patients and families, sat down and tried to work out what's important, what would make for successful transition. We then sent it out to over 15 organizations, and we got the endorsement not only of the Child Neurology Foundation and Society, but the American Academy of Pediatrics, the Academy of Neurology, and as of this morning, even though I made these slides recently, we got the endorsement after the fact of the American Epilepsy Society, so that these principles that I'm about to tell you about are broadly supported. How did we develop these principles? Well, not only did we bring together the interdisciplinary team, but we tried to review the literature, and where the literature didn't help us, we relied on expert opinion. We tried to develop these common principles and then show, as Stacia pointed out, 5 different, very different areas of child neurology, ranging from a simple seizure disorder to a very complex progressive problem, neuromuscular, neuropsychiatric, to show that these principles were generalizable. We sent it out, we got feedback, and we came up with the guidelines that were published this summer. The first principle, and I want you to remember this, is that there is a transition that's expected. Very few of our practices have a policy that's posted or sent to patients. We should have that. We should know what we're getting into, and that there is an expiration date, not just on your milk container, but on your relationship with the child neurologist. And we need that time, 6, 8, 10 years, in order to prepare to help the teenager and youth to develop the competency, knowing what his or her disease is, how to self-manage and how to advocate for themselves, to learn about the differences, like I've mentioned, between pediatric and adult care, and if there's special needs, to coordinate with the schools that are providing similar transition for educational purposes. The second is that this is not one and done, that we need to go back and think about this on a regular basis, and every year is pretty good because things are changing and kids are moving from middle school to high school, they're moving from high school to college, they're moving in and out of their special ed vocational services. We specifically ask the question, how should we do this? And ideally, perhaps it should be done in a separate visit. Certainly it should be done in a routine visit and not in crisis. So I like to say the time to learn how to swim is not when you're drowning. If somebody's in for a seizure activation, that's probably not a good time to talk about moving on to adult care. Each year, the issues may be different. It may be dealing with emerging sexuality. It may be dealing with who's responsible for taking medication. It may be how the disease or disorder affects driving, about whether or not the individual is ready to move on to a residential college, and certainly about risk-taking behaviors. There are many of our children who never have the full ability to be on their own. And this is a legal concept, not a medical concept, and we grappled with this because if for physical reasons or intellectual disability reasons they're unlikely to become fully independent, that needs to be dealt with before the age of maturity, which in most states is 18. And we need to advise people that it will not happen without their input. We looked at it and we said that this transition plan, such as it was, needed to be reviewed every year. The next sixth point is that it is not the child neurologist's full responsibility to deal with all aspects of the plan, but it is their responsibility to make sure that there is a plan, that the child, young adult, youth, whatever you want, is increasingly aware of his or her disease and how to take care of it, how to make appointments, how to get renewals, what their insurance is, what their acute management might be if there's a problem. And for those who are not ready, guardianship, as I've mentioned, and the child neurologist is also responsible for making sure that the neurologic aspect of the transition packet is complete. Now, what is a transition packet? Because this is very practical. It's the form that says what the diagnosis is, what the cause is, what the treatments have been, the procedures, what the current plans are, and especially what to do in case of an emergency. As we move along, the identification of the adult provider is not something that occurs at the moment of transfer, but it occurs at least a year in advance. And we need to recognize that it's not always easy because you can't always go to a neurologist if you have ADHD. That's often the care of a psychiatrist or a primary care provider. The last point is that transfer is not complete and transition is not over until the new provider accepts the patient shows up, and the appointment is complete. At that time, transition is over. What are a few practical considerations for parents and families and youths? Don't be afraid to bring it up early and often. Parents should, if the doctor doesn't mention it, ask whether or not it's good for the child to be in charge of their medicine, whether or not they should be in charge of making their follow-up appointments, etc. We need to encourage the teenagers and young adults to become as knowledgeable, as responsible, and as self-advocate as possible. Again, to make sure that the adult providers are identified in advance, and that can be done through talking to your primary care, through your networking of friends and other people with in the same position, and to your neurologist. Lastly, I would say that remember that the child neurology team are the people who are responsible for care until the point of transfer, and they should provide the DMV or the prescriptions until the youth has moved on. So in conclusion, the goal is not transfer, it's transition, and with that I'll stop and turn it back to Stacia.
Thank you, Dr. Brown, for that overview of the 8 common principles, the role of the child neurology team in transitioning to the adult healthcare system. Our next presenter today is Dr. Rebecca Schultz. Dr. Schultz received her PhD in nursing science from Texas Women's University in Houston, Texas, and her Master of Science in Nursing from the University of Texas Graduate School of Biomedical Sciences in Galveston. She is a nurse scientist and pediatric nurse practitioner with over 25 years experience caring for youth with neurologic conditions and their families. She is the principal nurse practitioner for the Comprehensive Epilepsy Program and the Blue Bird Circle Rett Center at Texas Children's Hospital. She is also Assistant Professor of Pediatrics and Neurology at Baylor College of Medicine, Houston, Texas. Dr. Schultz's research interests include the psychosocial aspects of epilepsy in youth, efficacy and side effects of the ketogenic diet, and transitions of adolescents with epilepsy from pediatric to adult care. She lectures at the local, state, and national level about the treatment and care of youth with epilepsy and transitioning adolescents with epilepsy to adult care. She is an active member of the National Epilepsy Foundation, Professional Advisory Board, the Epilepsy Foundation of Texas Houston Affiliate, the American Epilepsy Society, the Association of Child Neurology Nurses, the National Association of Pediatric Nurse Practitioners, and the Child Neurology Foundation Transition Project Advisory Committee. Welcome, Dr. Schultz. Thank you for joining us today.
Thank you, Stacia. Well, it's a pleasure to be here today to talk to you about preparing for transition to adult health care. At the end of our conversation today, I hope that you will have a better understanding of your role in planning for a successful transition for your adolescent, to help you set some expectations, as well as to identify strategies to help you prepare for transitioning your adolescent to the adult healthcare system. Transition to adulthood is a time of increased opportunity, but also increased risk. Life transitions can be both rewarding as well as worrisome as we move into novel situations and confront the possibility of success or failure. With age, the contrast between increased body size and immature cognitive functioning becomes sharper. Expectations of full independence sometimes now need to be adapted to more realistic goals. And as parents, sometimes when we begin to think about it, the future approaches with a barrage of challenges. Well, what makes this transitioning so difficult? What factors are involved? Well, for one, this is a time of experimentation for adolescents as they develop. Relationships change during transition. As parents, perhaps you can think back to your time of adolescence and some of the challenges that you had during that time. And as a parent, I certainly have been in the situation as depicted in the picture in the left upper hand corner, talking to my son and wondering, is he even listening, as he sits there and looks like he's saying, ho hum, I've heard this from the umpteenth time, when is she going to be finished? Or how many times have you heard, you just don't understand, as this mother is saying here, which unfortunately I don't believe it projects too clearly, but she's saying, it's you who don't understand me. I've been 15, but you've never been 48 before. So this is a time of great challenges. Our teens want their independence, and yet they want our comfort and love at times as well, and they need that. The needs of adolescents with chronic health care conditions are very similar to other youth. They change as the adolescent matures, but they still have the same desires for independence. They need an identity and a purpose. They strive for that. Everybody wants a job. That gives them identity. We need to help instill hope for future autonomy. But for children with chronic health care conditions or neurological conditions, this is often more complex and may require individualized care. So with that, as Dr. Brown has already indicated, the Neurology Foundation developed these common principles that we hope will be your tool to setting expectations for yourself, your adolescent, and your neurology provider. We know that transition can be difficult. Many parents have told me they feel alone or like they're falling off a cliff with no parachute. But we know that with planning and guidance, the move from the pediatric to the adult health care system can be made less stressful. We don't guarantee that you will have all mountaintop experiences, because you won't. There will be many days that the clouds will cover those mountain peaks. But again, with careful planning, you can be successful. Transition takes time. It takes time to locate resources and learn new information. It takes lots of advocacy, for some more than others, and tenacity. It isn't easy, and again, it takes time. So we recommend starting early. The first principle, as Dr. Brown indicated, is set an expectation, and have the expectation actually that you are going to transition. Begin discussions at age 12 to 13 years of age. This gives for your teen. This gives you time to prepare. Ask your neurologist when you will have to transfer to adult care. 18 years, 21, never? And how are they going to help you with this process? Or will they? Again, set expectations. You know your teen best. Talk to your teen. Encourage him or her to participate and begin taking charge of their health care needs. Don't underestimate the ability of your adolescent. This is something that I often encounter with parents. Even adolescents with intellectual disabilities can learn about their health care condition. And if they're not able to engage in this conversation due to their degree of disability, think about where you want them to be in the future. Set your aspirations high, but be realistic. Will they attend college? If not, that's okay. What about a vocational job? Or perhaps a sheltered workshop? Maybe they will stay at home. Again, where do you want them to be? Set your expectations about where you want them to be or see them in 5 years or 10 years. And who do you need on your team so that they can obtain optimal independence? It's important to teach self-management skills. Studies have shown that teaching self-management skills can improve adherence during this time of transition so that you don't fall off the cliff. And again, this takes time, so start early. As early as 12 to 13 years of age. Learning self-management skills is going to depend upon your teen's abilities. I recommend that you align this with the training or education that you're already encouraging your youth in obtaining independent living skills. You know, start small and gradually advance as they get older or as they learn the skills. It's baby steps, and it really starts with you. For instance, let your teen check in for their clinic appointment. You might be surprised what they can do and what they've learned just from watching you and your good role modeling through the years. You need to teach your teen about their healthcare condition, and your neurology team can help you do this. Help them learn the name of their condition, signs of illness. What about issues of sex, drugs, and alcohol? What impact does that have on their health condition? What are signs of emergencies? When do they need to seek medical attention? And help them develop an emergency plan. Revisit your emergency plan. Hopefully you have one, but you may need to think about what that plan is and update it. Perhaps your youth has worn a medical alert bracelet or a tag throughout his childhood years, but maybe they don't want to do that anymore because that's not cool. So what about a wallet card or a card that you put in their backpack that has their diagnosis, their medications, allergies, emergency contact information, or medical contact information? Program ICE, which stands for in case of emergency, the number on their phone. I've had many parents tell me what a comfort this gives to them and allows them to let their youth be a little bit more independent and go out with their buddies. If you don't have ICE on your phone, you can Google it, and there are a number of apps and instructions on the internet as to how to download this app on your phone or on your teen's phone. Your teen needs to know how to manage medications. They need to know the names as well as the doses of their medicines. Help promote independence in taking medications. Have them talk to their provider about the side effects. Encourage them, if they're having trouble, for instance, remembering to take their medicine all the time or it's an inconvenient dosing schedule, ask the neurologist, is there another medication preparation, perhaps one that I could take once a day and still maintain my seizure control, for instance, rather than having to take my medication 2 or 3 times a day? It may be possible, and then they've improved their overall adherence to medications. There are a number of medication reminders out there that you can use on your cell phones now, or just the age-old pill box can sometimes be helpful. They need to know how to refill prescriptions. Let them start taking responsibility for that. They need to know how to schedule an appointment. Rather than you always scheduling their appointment, have them follow up and make that appointment. For some, they may have several different appointments with several different providers. They need to know who to call for what condition, what numbers to call. They need to know the importance of following up on lab tests, checkups, referrals, etc. This year, if it's appropriate for your adolescent and they're at this level, have them sit down with you as you choose your insurance coverage so that they understand the process of identifying and choosing the appropriate insurance for their needs, so that they know what their health insurance covers and what to do if they lose their current coverage. The goal is to make them as independent in this process as possible, because you may not always be there to help them, and you really want them to become in charge of their health. Encourage them to participate in the clinic visit. Let them tell the doctor or their nurse about their seizures or their condition, how they're feeling. Encourage them to answer the questions. You know, too often as a parent, and I see parents, you know, we're so used to being the person who knows all of the answers all through our child's life, and it's hard to let go. But we really need to let go and encourage them to answer the questions as well as ask questions during an office visit. It's also very important as your teen gets to be a little bit older to give them time alone in the clinic visit, time to talk to the doctor or nurse by themselves, so that this helps them become more independent. It also helps them learn self-advocacy, how to speak up for themselves. This is not something that is common practice in all offices, so you may need to talk to your provider and say, you know what, I'm letting Johnny come in today, and he's going to tell you all of his concerns and medications and all that stuff, but please call me at the very end so that, you know, everybody can come back together at the end and know what the plan is. Again, this helps promote independence and self-advocacy. There are several tools out that are available to assess readiness this is one that you as a parent could download from the Got Transition website that's cited at the bottom of the slide there. It has columns that one column is, and it's a checkbox type. One says, I know this, another, I need to learn, someone needs to do this, and who. And it covers many of these self-management skills that I've already talked about, such as I know my medical needs, I know what to do in case of emergency, I know about my medicines. Another tool is the Transition Readiness Assessment Questionnaire, similar types of questions with all ranging from not knowing how to do something all the way over to yes, I already have accomplished this skill. And you can see different questions about managing medications, appointment keeping, talking with providers. This is a way to document what your adolescent has learned and what they still need to learn in order to become more competent. Dr. Brown already talked about this, but principle number 4, legal competency. The age of majority in most states is 18 years, and at this time and age, that is the time when your teen has the right and responsibility to make certain legal decisions. We recommend that this discussion, again, start early, around 14 years of age, so that you can begin assessing decision-making capacity. This is particularly important for those who have a teen who may have some intellectual disabilities. For some, they may just need some shared decision-making so that, perhaps they can make some decisions, but they're not, they can't be responsible for all. So perhaps you just need a confidentiality waiver or a healthcare power of attorney. For others, you may need full guardianship. This process can be time-consuming. It can take 1 to 2 years. You may need forms from your school in order to assess their intellectual capacity, and it can be expensive. So again, I recommend thinking about and talking about this early. And in summary, transition is a process. Doesn't happen overnight. It's recommended you start early. This gives you time for your teen to learn self-advocacy, to practice that over time, and to learn self-management skills. This has been a journey of advocacy for many of you for your children. It's now time to turn that journey of advocacy over to your youth so that they can become adult advocates for themselves, so that they can maximize their lifelong potential. I will now turn it over to Christina.
Thank you, Dr. Schultz. Those were really helpful, practical steps for beginning and moving through this transition process. For all of you listening in, if you have questions for either Dr. Brown or Dr. Schultz, please just note that in the chat box and submit your questions. And after our third presenter, we'll take some time for questions and answers. Our third presenter today is Cristina San Inocencio. Cristina is the founder and executive director of the LGS Foundation, the leading organization in the world dedicated exclusively to Lennox-Gastaut syndrome, a rare and severe form of childhood onset epilepsy. The mission of the LGS Foundation is to improve the lives of individuals with Lennox-Gastaut syndrome through research, programs, and education. Ms. San Inocencio was inspired to start the LGS Foundation by her brother Michael, who has been living with Lennox-Gastaut syndrome for 25 years. Cristina also serves as a board member of the Epilepsy Leadership Council, a member of the Transition Project Advisory Committee, and a steering committee member of the Rare Epilepsy Network. She has served as a peer reviewer for the Department of Defense's Epilepsy Program and is a committee member for the American Epilepsy Society's Communication Council. Cristina holds a master's degree in communication, an advanced graduate certificate in health, communication, and public health, and a Bachelor of Fine Arts in Electronic Media. She is currently pursuing her PhD at the University of Maryland, where her research focus is on health and science communication. Other research interests include the media's role in health-related public policy, public health awareness campaigns, rhetoric of health issues, and medical transitioning. Thank you for joining us today, Christina.
Thank you very much for having me. It's a pleasure to be here. I'm just going to share my slides from here, so just bear with me one moment. Okay. So I am so excited to be here talking about transitioning from the family perspective. As Stacia just said, I am a sibling of a 29-year-old man who's living with Lennox-Gastaut syndrome. So about me, I think Stacia really covered some of my background, but what I really wanted to do is highlight my inspiration, who is Michael. Michael, like I said, is 29 years old, and he's been living with Lennox-Gastaut syndrome since the age of 3. Interestingly and appropriately for this webinar, we are still ongoing in the transition area. It's almost complete, we think, at this point, but we've had some major hiccups and hurdles throughout the transition process, which I'll talk about later. So my perspective for this presentation will really be not only on the Lennox-Gastaut syndrome perspective, but also speaking on behalf of the majority of complex neurology cases. And what's really interesting about these common principles, and what I find so helpful about the common principles, is that they're relatable not just from the clinical side, but also the family side. So I've highlighted 4 specific common principles that I think are most helpful for families. And I will go through them now. So the first one, which you've heard about from Larry, is the transition expectation and the date or the due date to set for the discussion to happen. Why is this so important from the family perspective? Well, at the age of 13, there are many things happening in the child's life. They're going through transitioning through school. They have to coordinate with the idea. They're going through puberty, and all these other changes are happening. So it's inevitable and almost natural that the discussion happen about transitioning into the later years of the individual's life happen at a certain stage. The second that I wanted to highlight is legal competency. This is a major concern for a lot of families, especially those who are living with Lennox-Gastaut syndrome or have a complex neurologic disorder. So one thing that I wanted to really address is legal guardianship and power of attorney, which you've already heard a lot about. But what is really important here is that if a youth's legal competency is unclear, it's important to do a yearly assessment. And I think this is really important because when families are essentially living in the trenches, battling things like daily seizures and multiple medications and many, many different doctor's appointments, it's important to revisit legal competency every single year. The third that I wanted to highlight is the collaborative transition plan. You know, life with a child with a complex neurologic disorder is overwhelming. So it's important, this is important to families because families, especially those who have a child with a complex disorder, they tend to be accustomed to coordinating different aspects of their child's care every day and are kind of required to see a number of different specialists. So having a comprehensive plan that organizes and collaborates all of the different actors in the child's transition activities is extremely, extremely helpful. And as we know, not just one discipline will be affected by the transition, so collaboration and communication are extremely important. And then the fourth principle that I wanted to highlight and make it applicable to the family perspective is identifying an appropriate provider. Recommendations are incredibly useful for families so they have a starting point. It's very overwhelming when you are making this transition, and like Dr. Brown had mentioned before, the child or the pediatric neurologist sometimes has known the family for 20 years. So making this transition can be very, very difficult. But families, they need these recommendations from their primary care provider to be able to make the next step. So identifying an appropriate provider early on makes that transition a little bit easier. So now I want to segue to expectations from the families for the transition process. And the first is somewhat obvious, but it's to plan ahead and plan your own roadmap for the other situations that may not be covered in clinic. With the transition plan and some other resources that are available for families, they do list certain ages and other criteria and things that you should be thinking of long term. But that may not be appropriate for you or for your child. So planning ahead and creating your own roadmap is very, very important because you can realistically plan what's most important. The next is asking questions. Of course, asking questions doesn't just have to, asking questions to your physician, he or she is not the only person that can help you. You can also ask nursing staff or school teachers or friends from programs that the individual is in, like the Special Olympics, for example. But what I really want to bring to everyone's attention here is asking questions to your other family members is also very, very helpful. For example, when we began the transition process for Michael, my brother, my parents had sat me and my other brother down and said, you know, where do you see Michael? What are your expectations from him? And it helped my parents be able to lay out a roadmap that would be most helpful for the entire family. Also, do research. Look at resources like Got Transition, which we saw from the previous presenter slides, or check with your local ARC or Epilepsy Foundation. Especially local organizations and nonprofits can help you with resources that are applicable to your state. Next is to connect with others. Support groups are extremely helpful, but also so is Facebook and other social media. Family conferences are as well. If you have a disease-specific organization that hosts a family conference like the LGS Foundation does, you could check in with them to see if their upcoming conference is offering a session on transitioning and or adults with the specific disorder that your child's affected by. Also, know you're not alone. I think this is a very, very important topic to address because, you know, I think sometimes when you're in the trenches again and you're just battling with so many different unknowns, it's sometimes hard to understand that there are other people out there who are going through exactly what you're going through and that there are resources out there available. And of course, be prepared for bumps in the road. Transitioning is not an easy process and you will be faced with difficult situations. But being as prepared as possible can make those bumps less jarring. And finally, I wanted to talk a little bit about strategies for families. And I just wanted to call attention to this photo here on the right-hand side of the screen. This was taken from the LGS Foundation Conference a few years ago, back in 2013, where some of these children weren't even, or the parents of the children weren't even thinking about transitioning, but now are going through that process. And you can see the range of ages too in this photo, ranging from about 3 or 4 years old to almost 50 years old. And some of these families are still essentially transitioning. So how can a family use the common principles to set their expectations? So the first thing that I wanted to talk about was talking about it, talking it through. Be prepared in your clinical appointments with a list of questions that you want answered ahead of time. Another is the roadmap, which I just mentioned. But I consider this, the reason why there's a rocket ship here is because I almost consider the roadmap as a flight plan, because you're embarking on this foreign journey through outer space and it may seem mysterious and sometimes you might be scared. But if you take a step back and you appreciate the beauty of the situation, it'll be helpful to put it into perspective. It's kind of like the poem called Welcome to Holland, if anybody on the call knows. It's a really, really great poem about having a son with autism and putting into perspective about the different journeys and places that you'll go. I highly recommend it if anyone has not read it. The third is creating a calendar. 5 years from the time that the first discussion takes place at around age 13 to the time that the individual is 18. That's 5 years, but it goes by very, very fast. So try to pace yourself, but know what's next. That's what I really like about the common principles, because they're ensuring that all stakeholders are responsible for making sure that things are happening at a certain time. And speaking of time, I wanted to, of course, acknowledge the amount of time that it takes from the caregiver's perspective between going through one appointment to another and running around all day and doing all of this while you're battling medical conditions like seizures and feedings and changings and all of these other aspects of managing a chronic or a debilitating disease. But it's also important to note that time in the office in the clinical setting is also very precious. And of course, unfortunately, transition costs money. And why is this important to families? Well, because hiring an attorney, for example, to be able to help with legal guardianship, that could cost between $2,000 and $3,000. So if you're not prepared for these financial obligations, it may make things more difficult. And the handshake. So the handshake is very, very important because it ensures that all parties are comfortable. one thing that we joke around in my family about is that after the transition was basically completed or near completion, we had a transition party where we actually just celebrated kind of putting all the transition obstacles behind us and celebrating a new phase of Michael's life. And of course, there's the thumbs up when everything goes very, very smoothly. And so finally, I want just to close with some expectations that families from the LGF Foundation have explained what they think is most important for their clinical team to know. So the first is that the team should always be honest. Be honest with the families. It's the best policy, and it helps us set our expectations realistically. Second, know you're not expected to know everything. Families understand that healthcare providers can't give them advice on every aspect of transitioning, like group homes or day programs or the legal process. But if a healthcare provider can actually point them in the direction of some resources, it goes a very, very long way for families. And that kind of segues into the next point, which is that you care. You don't want your patients to fall off the transitioning cliff either, and giving them those resources at the ready. Something tangible to look into after the appointment is always helpful. Brochures of organizations that they can refer to, the GOT Transition website, things like this are really important, and it makes the families feel comfortable and knowledgeable. And so with that, I want to thank the Child Neurology Foundation again for inviting me to speak, and it was a pleasure to be here, and I'll take questions and pass it over to Stacia now. Thank you.
Thank you, Christina. That was a wonderful perspective through the eyes of the family. And for all of you families listening out there, I just want to point out that you can access the paper and the common principles on the Child Neurology Foundation website. If you go to our website, childneurologyfoundation.org, and click on the patient caregiver menu, you can choose the transitions menu item. And from there, there is a link to the paper. And you can take it into your provider and you can say, these are the new published principles in the field of child neurology, and I want to discuss how we can get started with my child. So with that, if there's any more comments from our presenters, please chime in now. Otherwise, we can take some questions. Okay. So the first question we have here is for Dr. Schultz. My niece is 18 years old and has epilepsy. She is the light of my life, and I'm excited to see her excitement about becoming an adult. But I can also see my sister is having a hard time letting go, including letting my niece manage her daily medication regime. My niece wants to call in her own refills. Do you have any tips of how I can talk with my sister about changing her role as my niece's caregiver?
That's a good question, and a challenge that many parents face. Again, I kind of alluded to in my talk is that it's difficult for parents to let go. I mean, we've been there to make sure our child is safe and they don't miss any medicines and everything for much of their life. But it's important, again, to help them learn how to be independent. So one thing that I sometimes recommend for parents in this situation is let your teen call in their prescription. They need that practice. You may find that your niece is very competent in calling that in. On the other hand, she may think she is, but there may be a few steps that she needs help with. So I would encourage you to have your sister just, step back, let her do it, observe her for a few times, and I think that, perhaps she can feel a little bit more comfortable. And again, I often find that parents say, wow, I didn't know my teen could actually do that. But it does take time.
If I could just add to that, this is Larry Brown, that as we just heard from Christina, the doctors don't always have all the answers, and they're not the only ones to ask. I think that there are peer advocacy groups and educational opportunities to really find out whether or not somebody is ready and how they can self-advocate We emphasize strongly the epilepsy camps, for example, which allow kids to learn some of these principles and to feel more competent about their own medical conditions. And as Becky just said, there are times where kids will think that they're ready. I can think of an example of a 16-year-old who said that he's 16, therefore he could drive, and the first thing he did was grab the keys of the car and get in, but this was an intellectually disabled autistic young man, and he forgot one thing: he never opened the garage door. So there can be a reality check that's necessary from time to time.
Great responses. Thank you so much. Christina, do you have anything to add to that?
No, they both covered it wonderfully.
Okay, our next question comes in and says, to all presenters, have you heard of using the nurtured heart approach with teens to help them build inner wealth, learn self-regulation and self-management, and learn to advocate for themselves? Any of our presenters heard of the nurtured heart approach?
I personally, this is Rebecca, I personally haven't heard of that approach, but as Dr. Brown just alluded to a couple minutes ago, there are several programs out there and camps and the like that do help with these, help with the building self-advocacy and et cetera.
Similarly, I've never heard of that particular approach, but the education of the youth and the opportunity to push their limits and to take on the full responsibilities of adulthood in a meaningful and realistic way is something that we're all aiming for. And after this, I will look into it.
Thank you. Christina, this is a question directed to you. How should I look for an adult provider for my daughter?
It's a great question, one the Foundation receives pretty often. I think the first step would be to talk to the pediatric neurologist to see if they have a relationship with any adult providers. In the case of Lennox-Gastaut syndrome, it is a very complex form of epilepsy. So the pediatric neurologists often do have recommendations of adult providers who understand Lennox-Gastaut syndrome and the different comorbidities associated with it. If the child neurologist doesn't have any recommendations, I would go to your local epilepsy foundation or the disease-specific organization to see if they have any recommendations. So what we do at the LGS Foundation is we get requests like this fairly often, and if we don't have a recommendation for them, we'll connect them with another family who's gone through the transition process already to give them their experience and recommendation. And then the third option would be to look at the National Association of Epilepsy Centers, which is naec.org, I believe is the web link. But if you Google it, it'll come up very quickly. And they are a list of level 4 epilepsy centers located all over the United States, and you can search by specialty, so pediatric versus adult. So hopefully within those 3 resources you can be directed to somebody that you feel comfortable with as an adult.
This is Larry. I think that's a great answer. I would just make 2 comments, and those are the outliers. Either those who have such rare diseases or such complicated disorders that are only treated in a pediatric hospital, even through adulthood, that they may not be necessarily transitioned, but that's something to work out with your providers. But the other one is much more common, and we haven't mentioned it yet, and that is the fact that there are only 1/10 the number of pediatric neurologists as there are adult neurologists in the country, and in many places there are no pediatric neurologists. So it's not unusual for a teenager or even younger to be followed by somebody who is primarily an adult neurologist and will not necessarily transition physically from one provider to another. My recommendation to the family under that circumstance is still to make sure that in the process of transition, the teenager and young adult is pushed and expected to take on the mantle of adulthood the same way we've been discussing in preparation for transition to a different provider. In other words, there's still a transition going on even if there's not a transfer.
Great tips and insight. Thank you both. Leading off of this question is for Dr. Brown. My son has just turned 17, and I've been thinking about transitions for some time. However, when I've tried to talk to his neurologist in the past about anything related to transitions, I've been told too early to talk about it. How can I get him to see if it's time to talk about transitions and help me?
That is a really great question, and it's not uncommon because we really have not had any tools designed specifically for neurology, or even if it is available to a degree for the particular disorder faced by the family and child. We do now have some, and that starts off with the consensus statement that was published this summer. And in the coming year, we hope to make this all very practical and accessible. Right now, you can go to the same website you've heard several times at transition.org and see the ways in which you can help the provider to think about the way to prepare for transition, but that's not yet available specifically for child neurology. Within the year, our transition advisory committee hopes to have that readily available and up and running with access through the doctor's electronic medical record. Anybody else have a comment?
No. Well, I think that was great.
Yeah.
Okay. Dr. Schultz, this question comes in for you. It sounds like you have a lot of experience working with families. What's the biggest misstep you've seen patients and families do when it comes to transitions, and or the best strategy you've seen used?
I think one of the biggest is not starting early enough, or well, there's several, I guess. It's hard to know exactly which one is big. So I guess I'll pick out, highlight three. So not starting early enough, putting it off, thinking there's time to do this later. And second of all is I think it's very difficult for parents to give our adolescents wings. I mean, even if you have a child that doesn't have any health care conditions, it's difficult to give them their independence. So, and then not planning for and assessing their legal competency until the last minute. That can be a real problem if you wait until 18 and then suddenly you're trying to scramble and put all that together. I think one of the examples that I've seen that has worked quite well, and I'll give an example of one of the families that I recently saw. Her son is about 16 now. Actually, I think he just turned 17. But she's now been working with, and he has some mild to moderate intellectual disabilities. But we as a team have been working over the last couple of years in helping him become more independent and learning some self-management skills. So I expect him, and I give him an assignment every time I see him. So it started out with, tell me the names of your medicines. Well, he didn't know. So I asked him, well, do you know the color of your pills? Well, he could tell me that, and he could tell me how many he took. And so we started simple. The next time, his assignment was to know the name of his medicine. He managed to learn that, and we continued to build on this. So this, when I saw him last week in clinic, he was able, his mom came in and said, you know, he's going to give you his history today. I'm just sitting back and I'll fill in where he doesn't remember. He was able to tell me if he'd had any seizures. I obviously confirmed that with Mom, but he was correct. And he was able to tell me all of his medicines, the name. He still didn't know the milligram size of his tablets, so he still has a little bit to learn. But he's made huge progress over the last 2 to 3 years. I find that many parents in that same situation tell me, oh, Johnny can't learn that. Don't you know he can't do that. And so they're, you know, that unwillingness or concern that, oh, he can't do that, rather than encouraging them to take the baby steps. He could be surprised. And even learning how to check out. He was, this adolescent I was just referring to, he walked, I told him when his new appointment, or when I wanted to see him back, his mother made him walk out to the front and ask for his return appointment. We get out there, he's already forgotten in the length of the hallway when I told him, but I reinforced that, and he then told the scheduler when he wanted his appointment. So I think, again, it's a process, and it's a good example, I think, of how you can teach your adolescent and be successful. And he will never be completely independent, but that gives him some autonomy over his health care.
If I could just add, knowing you, Becky, I am sure that young man had some intellectual disabilities, but in my practice I sometimes encounter kids who are off to college and have driven their parents into the office, and still they don't know their prescriptions or what to do if they ran out of medication, or what to tell if they went to an emergency room with another seizure, and that really upsets me. And we have obviously in that case failed to do what you seem to do so well.
Well, it does take time, and that's the difficult, I think, thing in our offices that all of us, parents as well as us providers, struggle with, is the time that's allotted in a clinic visit to be able to address these issues. But I think that's why, as you, Dr. Brown, indicated earlier, it's best to try to do these in a non-acute situations, or some of these issues with learning medications, I think that can be done with the nurse in the office. Perhaps you can ask the nurse to help with this. There are handouts that we use in our office for that assignment. That, for instance, you don't know the name of your medication. Okay, here's a list of things that I want you to know this next time when I come back, so that it doesn't take up a lot of time to do that, and yet you can still be encouraging these learning these self-management skills.
High expectations.
Right. But if you don't have high expectations, you'll never meet them.
Absolutely. Christina, I just want to give you a chance to chime in from the family perspective if you have anything to add.
Sure. So could you just repeat the question, because I know I had something that I wanted to address in the question.
Yeah, the question is, what's the biggest misstep you've seen patients and families do when it comes to transitions, and or the best strategy you've seen used?
So just to piggyback off of something that Becky had said about there not being enough time and waiting too long, one of the things that we've seen just from the family perspective, but also from the foundation's perspective, is the lack of preparation in terms of obtaining legal guardianship in time. So I know we've talked a lot about the medical transition aspect, but there's also this legal guardianship aspect, which I touched upon a bit also. And what the scary thing is about legal guardianship is if it doesn't happen before the age of 18, then you are no longer the guardian of that person once they turn 18. And that can be really difficult in a hospital situation where you don't actually have a legal right to be able to, provide input, for your child in a healthcare setting. So that's something that we caution families about pretty often, and it's something that we see, unfortunately, too often that happens too late.
Okay, that's great. Good input. And I'll just give Dr. Schultz and Dr. Brown and Christina one more opportunity to say any closing remarks. Otherwise, we'll wrap up the webinar.
Well, the only thing that I would like to remind everybody is that as I hope we made this no more complicated than it had to be. It is complicated. It is a process, but it is not insurmountable, and it's something that if you really do want to help your child or your patient to achieve his or her full potential as much as their God-given ability is, that we are all there to help. And hopefully in the coming months and years, we'll make it even easier, and we will prove to the payers that this is important, and we will find coding for all of the extra time that it does take. But we are all in this together, and we all have the same aim to achieve the best.
And I guess in closing, I would just like to mention or the fact that there are some resources available on the Child Neurology Foundation website, and we plan to also increase some of the resources that are available. We have some there posted that with some tools to help through this transition process that are really targeted toward the adolescent as well as you, the parent, and so you might want to check that out as other helpful resources. And I don't know, Stacia, if you can point out where that is, or.
Sure. Yep, that's just at childneurologyfoundation.org, and then under the Patients and Caregivers menu, you click Transitioning into Adulthood, and that's where you can find those resources listed. Christina, do you have any closing comments?
Yeah, so I'd just like to reiterate one thing that I said in my presentation was for families just to know that they're not alone and to seek advice from the disease-specific organization that best represents their child for any other further information or insight that they can provide you with in the transitioning process, because it is complex, but you aren't the only one going through it.
Well, many thanks to our three presenters today for your time and expertise, and thank you to all of you who have listened in. I've had a few questions about the recording, and yes, if you registered for this webinar, you will be sent a recording, so look for that in the coming days. It will also be posted on that same web page when it's ready, so you can access it there too, and feel free to share with your friends and family and other constituents within your community. So from all of us here at the Child Neurology Foundation, thank you for joining us, and have a wonderful weekend.